Hello again, and welcome to this lecture on myocardial ischemia. Whenever you're assessing a patient with chest pain, one of the first questions you have to ask yourself is this a STEMI or not a STEMI? And the reason is STEMIs will require urgent management. Now, of course, don't forget your non-cardiac causes of chest pain, and some of those will also require urgent management, for example, a tension pneumothorax or aortic dissection. But this is a ECG lecture, so we're going to focus on cardiac causes today. Now, most STEMIs are pretty obvious on the ECG, but sometimes they're not. So, for example, a posterior STEMI is not always that apparent, and these other ones are also not so obvious. So we're going to work through the basics and then each of these special cases one at a time. So this is the Queensland Health Possible Cardiac Chest Pain Clinical Pathway, and it really is a great resource for helping you to manage patients with possible cardiac pain. It gives you step-by-step instructions on both investigations and management, and as you can see, the ECG is the first investigation required. Now, it should be reviewed within 10 minutes, ideally by a senior medical officer, but that's not always possible. Now, we're going to go through the ECG criteria for reperfusion, so let's focus on those. So the indications for reperfusion, they're not just ECG criteria, okay? Obviously, you need to have chest pain or at least some sort of history that makes a myocardial infarct likely. But the ECG criteria, you need ST segment elevation of at least 1 millimeter in the limb leads or at least 2 millimeters in the chest leads. You can also, if you also find a left bundle branch block that's new or presumed to be new, then that is considered evidence of a STEMI. Now, often this will be quite clear on the ECG, but if it's quite an abnormal ECG and you're just not sure if you're meeting these criteria or not, then I want you to notice this here. Contact the cardiology referral service. Okay, it's better to involve the cardiologist even if it turns out ultimately to be unnecessary. You know, they're not having an acute coronary syndrome. It's better to involve them than to miss a big STEMI, and I have seen it happen. So if you're not sure, ask for help, be it a more senior emergency doctor, the medical registrar, or the cardiology registrar. But if you're not sure, definitely ask for help. What do you think of this ECG? Is this a STEMI or not a STEMI? Now, I imagine this ECG is not too difficult for you to interpret, but let's go through the basics of the different findings that you get with myocardial ischemia. So what are the changes that you get on the ECG when the patient has myocardial ischemia? Well, the first sign is hyperacute T waves. This occurs quite early, and basically they're just quite tall T waves. Then you get ST segment changes. Now that might be ST segment elevation or ST segment depression. Either one can be cause for concern. Then you get the development of Q waves. This doesn't happen in every case. And T wave inversion. Now, to make the diagnosis, these changes should be present in two contiguous leads, as in two leads that are side by side. If you are always checking for these changes on the ECG, then you're not going to miss a STEMI. Okay, even in the more subtle cases, at least one of these signs will be present. So if you assess every ECG for these four things, then you're not going to miss a STEMI. You should also try to figure out which part of the heart is ischemic. And you do that by identifying which leads have the ischemic changes in them and which region of the heart they correspond to. So as you know, each lead looks at the heart from a different angle. You can see them on the diagrams here. So the inferior leads are leads 2, 3, and AVF. And as you can see, AVF looks directly at the bottom of the heart, and then lead 2 and 3 look at the left and right, respectively, sort of 30 degrees off that midline. Then we've got the lateral leads, okay, and it's all pretty logical. Lead 1 directly out to the left, AVL looking slightly upwards and to the left, and then V5 and 6 are placed quite laterally on the chest wall, so it makes sense that these are our lateral leads. And then our anterior leads, and again it makes sense V2, 3, and 4 are placed across the anterior chest wall, and they look at the anterior aspect of the heart. Now, when you're looking for ST segment elevation, you also eventually end up looking for reciprocal ST segment depression. Now, in a patient who's got inferior ST segment elevation, the reciprocal depression, well, there are no superior leads, so where do you see the reciprocal depression? You generally see it in the high lateral leads, okay, and that's lead 1 and AVL. On the other hand, if your patient has a lateral STEMI with lateral ST elevation, then your reciprocal depression might be seen in leads 3 and AVR. And for an anterior STEMI, well, again, there are no posterior leads, at least not in the standard ECG, so your reciprocal depression, it's best seen in the inferior leads, so 2, 3, and AVF. Going back to our original ECG, which region of the heart is ischemic? Well, we've got ST segment elevation in lead 2, lead 3, and AVF, so that's consistent with inferior ischemia. Now, when you've got inferior ischemia, you expect the reciprocal depression to be in the high lateral leads, and that's certainly what we've got here. We've got a small amount of reciprocal depression in lead 1 and a small amount in AVL, a bit more obvious in AVL. As well as that, we do have a small amount of ST depression in V2 and V3, and that's consistent with posterior ischemia, although we'll talk a bit more about that later. Okay, what about this ECG? Well, we've got ST segment elevation in V2, V3, V4, V5, V6. We've even got a little bit in leads 1 and AVL. So this is most consistent with an anterior infarct. Certainly the most marked elevation is in V3 and V4, but as you can see, we're extending into those lateral leads as well, V5, 6, 1, and AVL. So this is an anterior STEMI with lateral extension. Now, what about our reciprocal depression? Well, with an anterior STEMI, you expect reciprocal depression in the inferior leads, and that's what we've got here. We've got reciprocal depression in lead 2, lead 3, and AVF. Okay, so what about this example here? Is this a STEMI or not a STEMI? I'll give you a moment to think about it. Pause the recording if you need to. Alright. So this is a posterior STEMI. Now, when you're looking for a posterior STEMI, what you have to understand is that all the usual changes that you see in a STEMI have been flipped upside down, because although our leads are placed on the front of the chest, all the changes are happening on the posterior aspect of the heart. So our usual ST segment elevation has become ST depression in the anterior leads V1 to 3. Tall, broad R waves, upright T waves, and a dominant R wave in V2. These are the features of a posterior STEMI. It's really that ST segment depression that's important to look for in the anterior leads. And as I was just saying, these are the same changes of a STEMI, they've just been flipped upside down. So ST segment elevation in a normal STEMI is seen as ST segment depression in a posterior infarct. Q waves, which you would see in a normal STEMI, present as upwards deflection, so as R waves in a posterior infarct. And inverted T waves, well, they look like upright T waves in a posterior infarct. And this is why people say that if you flip the paper over, it might be easier to recognize as a STEMI. By flipping it over, it looks more like the usual changes you expect to see. So if these ECG features lead you to suspect a posterior infarct, then you can do a posterior ECG to prove the diagnosis. And so to do that, you record a posterior ECG by placing V7, V8, and V9 on the back of the patient's chest. V7 is at the posterior axillary line, V8 is at the tip of the scapula, and V9 is at the paraspinal region, and they're all level with V6 in a horizontal plane. The position is not particularly important for our purposes, but once you do the posterior ECG, it only takes 0.5 millimeter of ST segment elevation to diagnose the STEMI. So here's an example. So we're suspecting a posterior ECG because we've got R waves, dominant R waves in V2, ST depression in V1, 2, 3, upright T waves, and now the posterior ECG has been done. So usually what happens, V4, 5, and 6 are removed and moved around to the back in the positions that were demonstrated on the last slide, and then they're just relabeled V7, 8, and 9. So these are our posterior leads, and as you can see, there's ST segment elevation and Q waves, which confirms the diagnosis of a posterior STEMI. Here's another example. Is this a STEMI or not a STEMI? I'll give you a moment to go through it, and then I'll talk it through. So hopefully you've noticed that this is a STEMI. So we've got pretty clear signs of an inferior STEMI. So we've got ST segment elevation in lead 2, lead 3, and AVF. And we've got reciprocal depression in our high lateral leads, so that's lead 1 and AVL. Now, the reason I've thrown this one in is because there are some signs on this one that I want you to notice that make it a bit different to usual. So there are signs here of a right ventricular infarct. So what I want you to notice, the extent of the ST segment elevation in lead 3 is greater than the ST segment elevation in lead 2. That's significant because they both look at the heart from about the same angle, but from the left and the right. So lead 2 looks in from the left, lead 3 looks in from the right. So if there's more ST segment elevation in lead 3, then you suspect that the right ventricle is involved in this infarct. By the same token, V1 and V2, they also look at the heart from different angles, with V1 being more on the right. And so if there's more ST segment elevation in V1 than there is in V2, then you suspect right ventricular involvement. And really any ST elevation in V1, seeing as it is placed on the right side of the sternum, that should always make you suspect right ventricular involvement. Now I will point out that in this ECG, like in this example, the ST elevation V2 is greater than V1. But if it had been greater in V1 than V2, then that would be a classic example of a sign of right ventricular involvement. So just to go over it again with a diagram, you can see lead 2 here and lead 3 there. So they're about 30 degrees out from the midline. So lead 2, 30 degrees out to the left, lead 3, 30 degrees out to the right. And so it makes sense that if the ST elevation in lead 3 here is greater than in lead 2, then the right ventricle is probably involved. And in the same way, V1 is placed on the right side of the sternum, V2 is placed on the left. And so once again, if there's more ST elevation in V1 than there is in V2, it makes sense that the right ventricle is probably involved. So why is it so important to notice, like you've already seen the STEMI, so why is it so important to notice that the right ventricle is involved? Well, people with a right ventricular infarct are very susceptible to hypotension, particularly when you give them nitrates, like GTN. And seeing as we give that to pretty much every patient having an acute coronary syndrome, it's something to be aware of, that you could potentially make a bad situation a lot worse if you give them too much GTN. These people will be unusually sensitive to it, so you have to be careful. So the signs to look out for, as we've already been through it, but we should also mention that anyone having an inferior STEMI, you should suspect them of having right ventricular involvement, and the reason for that is purely anatomical. So the inferior surface of the heart is usually supplied by the posterior descending artery, and the posterior descending artery arises from the right coronary artery in 90% of people. So if the posterior descending artery is involved, then you assume the right ventricle could also be involved. After that, you look for those ECG features that we mentioned before, ST elevation in lead 3 greater than lead 2, or in V1 greater than V2, or ST segment elevation in V1. However, whenever you see an inferior STEMI, to be sure, what you should really do is a right-sided ECG to confirm the diagnosis. So to do a right-sided ECG, the setup is almost the same as before, except the chest leads are just reversed. So they're in the same positions, but they wrap around the right side of the chest instead of the left, as you can see here. More commonly, people tend to just take V4 off from the left side and just swing it around to the right side and just record one extra lead, the right-sided V4. But in this case, we've got a full right-sided ECG in this diagram. Using this example here, we've just moved V4, so what would they generally do? They, like I was just saying, they unclip V4 from the left, swing it around to the right, and they just relabel it on the paper, V4R. So if you see that, you know that lead was actually placed on the right side of the chest. So here we've got the same example from before. We've got ST elevation, it's an inferior STEMI, lead 3 greater than lead 2. We're suspecting right ventricular involvement, so we've done a right-sided lead, V4R, and as you can see over here, there is ST segment elevation, and that confirms that the right ventricle is involved in this STEMI. Moving on to this example, is this a STEMI or not a STEMI? I'll get you to pause the recording here, and then I'll talk you through it. So this is an example of Wellens syndrome. It's considered a STEMI equivalent, and although there's no significant ST segment elevation on this ECG, what I want you to notice are the T wave changes. So we have biphasic T waves, meaning they go up and then they go down. Okay, biphasic is how we would describe that. We've got biphasic T waves in the anterior leads V1, 2, and 3, and inverted T waves in V4. Now, inverted or biphasic T waves are the diagnostic feature that you need to be aware of for Wellens syndrome. The most common variant, 75% of cases, they present with deeply inverted T waves. But in 25% of cases, we have these biphasic T waves that go up and then down, and it's in these anterior leads, particularly V2 and 3. It's important to understand the rest of the ECG might be normal, so this might be the only change that you see. There might not be any ST segment elevation or depression. However, even just these T wave changes is highly specific for critical stenosis of the proximal left anterior descending artery. And these patients often do poorly with medical therapy. So most of these patients you'll need to discuss with the cardiology team to determine the most appropriate intervention. The pathophysiology relates to transient anterior ischemia, and because it's transient, they may not have any chest pain by the time that you see them. The rest of the ECG might be normal, and even the troponins might be normal in these patients. So as long as you're aware of the T wave changes, then you won't miss it. So here's an example of Wellens syndrome, the Wellens pattern. As you can see, we've got deeply inverted T waves in V1, 2, 3, and V4, and V5. But certainly quite deeply inverted in these anterior leads, V2 and 3. Going back to our original example, this one is a bit more subtle. The T waves aren't particularly big, but they are biphasic, and just this pattern alone should alert you to the potential of ischemia in these anterior leads. Here's another example. Now, is this a STEMI or not a STEMI? Well, this is a paced rhythm, so it's quite difficult to interpret from the point of view of ischemia. As you can see, we've got these sharp little spikes. Now, we haven't really discussed pacing just yet, but these are pacing spikes. So the pacemaker is firing, and that is triggering these wide QRS complexes. And as we discussed in the first lecture, when you have wide complexes, you expect to have ST segment and T wave changes. So how do you know if this is related to ischemia or not? It's quite difficult to interpret. So how do you interpret the ECG in a patient who has chest pain if they've got a pacemaker? Let's be clear what we're talking about here. We're talking about a patient with chest pain who has a left bundle branch block or a ventricular paced rhythm. And let's not forget our basics. I'm going to quickly flash up those criteria from the start of this talk. So remember, anyone with a new or a presumed new left bundle branch block should be treated as a STEMI. So if this is new, forget these criteria that I'm about to talk to you about. If you've got a new left bundle branch block, then you just treat that as a STEMI. But let's say you do have an old ECG for this patient, and they always had a left bundle branch block, and now they come in with chest pain, and you're trying to look at the ECG and interpret whether or not the changes that you're seeing, are they consistent with ischemia, or are these normal changes for someone with a left bundle branch block? So the Scar-Bosa criteria can help us, and the easiest way to remember them, as one of the emergency physicians once told me, if you dance with discordance and cry with concordance. So dance with discordance, as in discordance is good, you can dance, you can be happy, your patient's not having a STEMI. Whereas cry with concordance, concordance is bad and it suggests ischemia. What do I mean by discordance and concordance? So looking at this example up here, we have discordant changes. And what I mean by that is the QRS complex is predominantly upright. The ST segment is depressed, it's gone down, and the T wave is inverted. Okay, so the ST segment and T wave are in opposite directions to the QRS complex. Okay, they're discordant changes. And this is a normal change following a left bundle branch block or following a ventricular paced rhythm. Okay, you expect discordant changes in the absence of ischemia. Here's another example. So in this case, the QRS complex is predominantly downwards, and our ST segment and our T wave are predominantly upright. Okay, again, discordant changes, dance with discordance. This is an expected change for someone with a left bundle branch block or a paced rhythm. The Scarbosa criteria tell us to be more concerned when there are concordant changes. So down here we have an example. The QRS complex is upright. The ST segment is also upright or elevated. There's ST elevation next to an upright QRS complex. And the T wave is also upright. So these are concordant changes. That's not expected with a left bundle branch block. That suggests ischemia. Here's another example. We've got a predominantly negative QRS complex and ST segment depression. Okay, so this is a concordant change, not expected to happen with a left bundle branch block. So when you see it, you suspect there is ischemia. One little caveat that I will add: although we do expect discordant changes, okay, we do expect the ST segment to go in the opposite direction to the QRS complex. If that ST segment elevation gets a bit too high, so greater than 5 millimeters, that's still suspicious for ischemia. So there should be some discordant change. If you've got a negative QRS, you should have some ST elevation. But if it's more than 5 millimeters of ST segment elevation, that's just too much, and you should still be suspicious for ischemia in that case. Alright, so hopefully the Scarbosa criteria can help you if you're assessing a patient like that. Okay, so you've got a patient with a left bundle branch block or a ventricular paced rhythm, and they've got symptoms consistent with an acute coronary syndrome. You're looking at the ECG. If you remember dance with discordance, cry with concordance, it might help you to identify whether or not there's some myocardial ischemia. I just quickly feel the need to mention that these criteria are specific, but they're not very sensitive. As in, if someone does not meet the Scarbosa criteria, that doesn't mean you can just say, yep, they're safe, definitely not having an acute coronary syndrome. They still might be, even if they don't meet the criteria. But they are pretty specific. So if someone's positive for the Scarbosa criteria, as in they do have those concordant changes, that's actually pretty specific, and you're not 100%, but you're pretty close to guaranteed that person is having some form of ischemia, myocardial ischemia. So here we have that same ECG with the changes highlighted. So in V1 we've got a negative QRS with a negative T wave, okay, concordant changes, and we've got ST depression with a negative QRS in V2, and in V3 for that matter. So concordant changes, signs of ischemia. Okay, this is our last example. So STEMI or not a STEMI. Alright, I'll get you to pause the recording here and then I'll talk you through it. Alright, the changes that I hope that you noticed on this ECG. We've got widespread ST depression. Okay, you should be able to see that in just about every lead, particularly these lateral leads over here. Alright, but we've also got ST elevation in AVR. And so what I want you to think about is left main coronary artery occlusion, okay? The left main coronary artery being before it splits into the left anterior descending and into the circumflex branch. So the features to be aware of with left main coronary artery occlusion are widespread ST depression, like we just saw, and ST elevation in AVR of at least 1 millimeter, or ST elevation in AVR that's greater than V1. Now, having said that, these are not specific findings. There are several differentials that you'll still need to consider, but if you've got a patient with chest pain and these ECG findings, then you need to take things very seriously with that patient. That brings us to the end of this talk. Just to summarize, these are the changes you need to look for: hyperacute T waves, ST segment elevation or depression, Q waves, or T wave inversion. Okay, and what I hope you've noticed is that if you look for these 4 things, you won't miss a STEMI. Even in the more subtle or unusual cases, at least one of these features will be present. So if you check every lead for these 4 things, you're not going to be missing anything on that ECG. Having said that, there's always going to be times you're unsure. If you're unsure, my first piece of advice, repeat the ECG. Get another ECG in 10 or 20 minutes, and if there is ischemia, the ECG changes should worsen or progress in some way. And if you're still not sure, call for help. Okay, it's even built into the guidelines. If you're struggling to interpret the ECG in a patient that you suspect might be having a myocardial infarction, get help from either a med-reg, a more senior emergency doctor, or from the cardiology team. Alright, that's it. I hope you feel more confident interpreting the ECG for patients with chest pain and when you're assessing for ischemia. I'll see you in the next lecture about conduction disease.